And thank you very much for inviting me to give you this short presentation in a subject that is very interesting to me, but also very interesting to many of you, if not all of you in Korea, since you have contributed a lot in this field. In general, when we talk about the risk of stroke, because at the end of the day, that's what we're talking about when we're trying to deal with antithrombotic therapy and TAVR, we're dealing with the risks related to aortic atheroma, new-onset atrial fibrillation, and leaflet thrombosis, and the interplay of those three with each other. And we also deal with the interplay of the possible medical therapies, antiplatelets or anticoagulants, or the combination, or perhaps only monotherapy of each one of them, in combination with valve-related factors and patient-related factors. And we try to make some sense out of that and figure out which patients and which drugs might be suitable for what type of post-procedural course. The field was shocked by images. And it's really this field in many ways have been shaped by imaging. And you can see here images of so many valves, either surgical or bioprosthetic transcatheter, that indicate clots. And it's not like those things never existed before, but we just couldn't see. In the CT video, the so-called 4D CT angio, that shows now is able to show the valve opening and closing throughout the cardiac cycle, enables this type of investigation. And initially, of course, in the absence of previous data of any sort, I think our community was a sort of clot sitting on top of the valve and having an impulsive way to try to get rid of them, in obviously employing some part of empiric antithrombotic therapies. And indeed, there were some registries and case reports, etc. They got a lot of publicity because it was, I would say, a shock finding. And they indicated that, again, in a registry mode, that if patients were not anticoagulated, there might have been some progression, but if they were anticoagulated, there was some regression. And this was the initial kind of thinking that perhaps should anybody have some form of anticoagulation regardless anything else. Over time, and we learn, and this includes now the latest study that included also surgical valves, that this problem is not specific to transcatheter valves. Maybe it appears a little bit earlier in the transcatheter valves. You can see on the left side in the randomization of a balloon expandable valve in surgery at 30 days, at 1 month, there seems to be some perhaps greater rate with the transcatheter valves, but at 1 year there is there is a catch-up with the surgery as well, and there is a 20 to 25% rate of this type of phenomenon of finding in the valve some clots in the valve, and the 20 to 25% of patients is really no small percentage. The other interesting part is that this phenomenon fluctuates. So it's not the same people who have the clot at 1 month, those who do have it at 1 year, plus some more. Not at all. Some of them who have it at 1 month may or may not have it at 1 year, and those who don't have it at 1 month, they may develop it at 1 year. So not only is a phenomenon rather common at 1 year, but it also fluctuates. That is a very, very important, with fluctuates like on its own, or with no modification on medical therapy. This is very, very important when we try to study this phenomenon, to not underestimate it, but also understand how dynamic this may be. It took us several years to come up with a very crisp definition of the stages, the grades of how important this phenomenon is, a reduced leaflet motion. And you can see at the bottom picture schematically how one can see the cup, that essentially every leaflet is a cup, and how full the cup is with clot. And the more clot there is, the more inflexibility occurs in the specific leaflet. And then you can have a valve analysis, a patient analysis, or you can even have a a leaflet-based analysis if you want to really have a lot of observations by the CT angiogram. And of course, in looking at the valve itself and other leaflets, we showed for the first time that very clearly even a medium dose of coagulation, intermediate dose of 10 milligrams of rivaroxaban was highly effective in preventing this clot. Highly effective. Something that was new initially. Everybody thought that only high doses anticoagulation would do this type of job. Unfortunately, we realized that when we're treating everyone with this type of therapy, namely with rivaroxaban, we end up having some untoward events in the entire population, although we had beneficial effects at the level of the valve, with increased MACE and mortality, as well as major bleeding, particularly at 1 year. Therefore, we're successful in something, but not really successful in the overall balance of thrombotic and bleeding risk in those patients, because bleeding is an important aspect early as well as late prognosis after TAVR. And in our analysis, we found that thromboembolic events and bleeding had a lot to do with mortality as well. The guidelines, for the most part, have American and European guidelines have gravitated towards simplicity in the absence of very definitive trials. You can see the 2021 guidelines. In general, one of the largest studies of patients with no anticoagulation is this pilot, essentially, study of 200 patients, 111 per group, the ARTE trial, that indicated no major benefit of adding clopidogrel, at the same time no major risk, but clearly everybody in this study, and this is a difficult analysis because everyone was preloaded with clopidogrel loading dose. Therefore, a lot of the upfront bleeding had a lot to do with a loading dose, which no longer used anywhere, I don't think, rather than the daily dose afterwards that would be geared more towards the durability of the valve. Another interesting European study was the study of Dutch of Holland that indicated that there's a lot of bleeding up front related to the loading dose of clopidogrel, but again, no difference between the two groups afterwards as the study follow-up evolves. Interestingly, on the right side, you can see that the aspirin alone group, those people who never received any clopidogrel, do have an accumulation of events over time, and the slope of accumulation of those events is somewhat different. No other study has performed this type of analysis, so we don't really know if this is a true finding or if this is something that is just a play of chance in this Dutch trial. For sure, the popular trial, the POP-TAVI, indicated that if you keep simple with the anticoagulated patients, there's no need to add clopidogrel to anticoagulation. At the same time, it did show that if you anticoagulate patients with an oral agent before the procedure, as this investigators mostly did, you're going to have a lot of bleeding, 10 and 20% from the get-go, as you can see on the left side. This is astoundingly high numbers of major bleeding, and for this reason, I don't think many people, many centers, so we certainly don't treat with oral anticoagulants ahead of the procedure. So there were dual, I would say, lessons from this study. Avoid the oral anticoagulants before the procedure, and no need to add clopidogrel to the oral anticoagulant. The French study came with the Atlantis trial with a little bit of a mixed group. These investigators gave a full dose of apixaban, not the low dose rivaroxaban we had investigated with, and they had dual comparisons. So I'm going to present those separately. The smallest study included just about 200 patients each for those who had indicated for oral anticoagulation, apixaban versus warfarin, essentially, the situation was just rather similar. When we go to apixaban versus antiplatelet therapy, though, in patients who didn't have an indication for oral anticoagulation, we have a clear repetition of the lessons from Galileo trial that indicate a higher mortality, non-cardiac and otherwise, with the anticoagulation versus the simpler antiplatelet therapy. There is some aspects of, again, benefits from the clotting in the valve, as you see at the bottom, but clearly doesn't outweigh the clinical adverse events. The overall results of the CT sub-study of the Atlantis, I don't think is of any was of any news. Overall results were not so significant because in the anticoagulated group, somehow apixaban didn't do as well as warfarin, whereas in the non-anticoagulated group, it did quite a bit better than the antiplatelet. So there was some interaction there, but the overall results not so significant. Interestingly, this investigator showed that even in the presence of a significant clot in the valve, we didn't seem to have any adverse event within a year. So if someone was to ask or be nervous, why would the clot travel? Where could the clot travel? Well, it could travel anywhere, but apparently it doesn't seem to travel very much so towards the brain that we always are afraid of. And particularly, so it may be related more so with the later adverse events of the valve, like the durability of the valve, same way perhaps a squeaky door, that if you don't oil it, it may malfunction in some time. But there doesn't seem to be any immediate danger of this clot dislodging from the valve towards the brain, and that is very reassuring. In the envisaged TAVR trial, we investigated with the edoxaban, and were able to show very clearly that was a non-inferior. You can see, as far as the NACE is concerned, the net adverse clinical event of both ischemia and bleeding, you can see the curves are superimposed. But on the right hand, you can see that with a prolonged administration, particularly beyond 1 year, we have to be careful, as there was some bleeding, particularly GI bleeding, and mostly, as we know from secondary analysis, those were treated with antiplatelets, as well as those who may have specifically AVM-related bleeding sources. Interestingly, we're able from this study to identify that the type of atrial fibrillation, the creatinine clearance, the age, and the various other aspects, including the excessive alcohol utilization, had a lot to do with predicting the mortality, and we'll be happy to present a similar analysis for a risk score for a bleeding in the next year, which we're conducting right now. In summary, I want to also include the study that you all know very well, because it stems from your own country, the ADAPT TAVR, and about 110 patients per group of a edoxaban versus dual antiplatelet therapy, and a dedicated CT at 6 months after TAVR, as well as serial brain imaging. We experimented with brain imaging in Galileo as well. There's just a scattergram of those findings in the brain MRI. It's always very difficult to have a very significant and clear message from the brain MRIs. For the most part, this reports of functional studies and the way the MRIs are analyzed in the brain, I'm not so sure we have a very good grasp of what these findings mean, and I'm not sure we have a capacity to analyze them very well. Interestingly, there was some reduction in the event rate, but overall things did not go in the significant range, perhaps because the study was rather perhaps a little limited in numbers, slightly smaller than some of the other studies I presented before, and maybe that was a difference here. But or perhaps the dosage did not work so well of edoxaban in the patients studied. But in general, I would say the flavor is just about the same that there's a reduction of those events with the doxabank versus antiplatelet therapy. Again, this is the MRI studies that I'm not surprised in the Bravo trial with the Angiomax or Beverly-Rudin. During the procedure, we were also puzzled about how the best way to analyze that. We had a secondary analysis of MRI in Galileo, very similar results. Interesting, yet a little bit all over the place from analysis point of view without a very clear finding, despite the big efforts of everyone to ascertain the MRIs in this very difficult population. So overall, a few things we do know and we have learned is that even low-dose anticoagulation is effective against the TAVR leaflet thrombosis. We also know that the monotherapy seems to be the most reasonable and practical option at this time where anticoagulation is needed. But if anticoagulation is not needed for any other reason, we don't need to bother anymore. And as well as we don't need to bother loading, and we should not load with clopidogrel before the TAVI. And if for any reason we employ a combination therapy, perhaps it was a recent stent or a concomitant stent or something like that, then we have to really reevaluate at every clinic visit the strategy of continuing the combination of the antithrombotic antiplatelet therapy, or we should just simplify it as soon as we can and following this tailored approach. And hopefully we try collaboratively to conduct further studies to clarify where we may be going in this very complex field, but in my mind, very fruitful for international collaboration and research, because a lot to do with the durability of the valve have to do about how well oiled all those, I would say, leaflets may be, particularly in the hinge points. Same way, we want to keep our doors not squeaky when we open them. Thank you so much for your attention, for the invitation, and I hope we see all of you, or most of you, in the Sky Scientific sessions for the West Coast, Los Angeles, this coming May.
Thank you, Professor.